Welcome, friends. My topic today is about primary sclerosing cholangitis. This disease is a chronic problem, and fortunately, it is a relatively rare disease because it turned to be life shortening and associated with a lot of morbidity to patients. In general, and by definition, this disease is considered as one of the autoimmune disease, and the autoimmune disease here is targeting the biliary tree and possibly the liver substance itself, but most evidently is that it is, or all the autoimmune reaction is against the epithelial lining of the bile duct, the cholangiocytes. It's a chronic disease manifest in the form of cholestasis in the liver. When you do a liver function test, the enzymes are elevated in an obstructive fashion with raised gamma GT and also raised alkaline phosphatase, in addition to the other enzymes. The disease tends to involve the entire biliary tree, intrahepatic and extrahepatic, and lead to formation of multiple strictures. And these multiple strictures are typically seen on imaging both in the intrahepatic biliary tree and extrahepatic biliary tree. As you see in the photo here, we have got multiple narrowings in the main bile duct and also multiple narrowing in the secondary radicals of the biliary tree on either sides of the liver. So the appearance of the biliary tree tend to look like a beaded appearance, usually described by the radiologist as a beaded appearance, where there will be a stricture, a dilated area, and then followed by a stricture, and so on. Occasionally, the patient could present with a single dominant stricture, and that can be problematic because when we see a single stricture, the likely diagnosis is a cholangiocarcinoma. But majority of the cases in primary sclerosing cholangitis, the process is diffuse and involves intrahepatic and extrahepatic biliary tree. The disease is chronic in its nature, and you'll see that these patients will advance gradually until they develop liver cirrhosis or they develop cholangiocarcinoma that could be either in the intrahepatic biliary tree or extrahepatic biliary tree or gallbladder cancer. And the risk of developing cholangiocarcinoma from the time of the diagnosis is about 1% per year. So the longer they live, the more likely they will get liver cirrhosis and cholangiocarcinoma. The disease is autoimmune, so it's associated with other other inflammatory, autoimmune inflammatory problems, such as inflammatory bowel disease, in particular ulcerative colitis. 70% of them will have ulcerative colitis of different severities. It's also related to the HLA antigen, which is B8DR3. So that's the definition of the disease and the likely course of it. Now we see how the disease gets presented to the clinicians. These patients, unfortunately, are young, with the mean age is 45, and usually patients are somewhere between the age of 20 and 50. No predisposing factor has ever been found apart from the genetic predisposition of individual patients. And the disease itself tends to run a very variable course from mild disease to a severe form of inflammatory problem with relapses and remissions. Patients often have a variety of symptoms that include weight loss, fatigue, pruritus, lack of appetite, nausea, and so on and so forth. Every now and then, some of them could present with the bacterial cholangitis because of the stricturing and the stasis, but this process is fortunately not that common, in the biliary tree where no stent has been placed, but the risk will be higher when stenting and dilatation start to be needed for these patients because of a dominant stricture. But fortunately, they are not common on their own. If you do a liver function test for them, as I mentioned earlier, the picture is cholestatic obstructive. Now, unfortunately, the life longevity and life expectancy in these patients is severely affected, and the median survival from the time of the diagnosis is about 12 years, somewhere between 12 and 15 years, because they do advance to liver cirrhosis and then they decompensate and die, or they develop cholangiocarcinoma and they could die from that as well. Now, how do we make the diagnosis firm? The diagnosis of primary sclerosing cholangitis relies on imaging, and imaging we mean MRCP and ERCP. MRCP is non-invasive and it's very sensitive, showing diffuse strictures wherever they are in the biliary tree, and it can show you the roadmap of the biliary tree inside and outside the liver, and the length and the number of all these strictures. For unknown reason, the most severely affected part of the whole biliary tree is the confluence, the hilum of the liver, where the left and right hepatic duct join together. If we find such a stricture in general or a single dominant stricture, we often advise the patient to have an ERCP with a brushing for cytology to rule out a cholangiocarcinoma. Also, what helps in the diagnosis is the blood test. These patients tend to have raised anti-nuclear factor, anti-smooth muscle, and anti-mitochondrial factors, which will help us to substantiate the diagnosis. But the diagnosis basically is based on radiology, and the MRCP and the ERCP is the cornerstone of the process of diagnosis. And every now and then you see a typical case and the patient is not behaving in the usual fashion, then we have to think about the other possibilities of why they are unwell with cholestatic liver function, i.e. we are going to look for other causes of liver cirrhosis, which is alcohol. We check their iron to ensure they don't have hemochromatosis, and also we check their hepatitis serology to ensure they don't have hepatitis B or hepatitis C that need to be treated. But as I said, this is only a matter of cases where the diagnosis is not 100% certain, and this occurs due to the variability of the severity of the involvement of the biliary tree in this disease. Now we've got the diagnosis secured. How do we manage them? In general, once the patient gets diagnosed with primary sclerosing cholangitis, if they are well otherwise, their only hope of long-term survival is a liver transplant. So they get followed up until their liver fails, and then they get liver transplant. There is about 10% chance of recurrence of the PSC in the transplant as well. ERCP plays a major role in the management, and if we see a dominant stricture, here where we do the ERCP, we take brushing, we dilate the stricture because these all are inflammatory, and we should be able to dilate them. They tend to be short strictures, and also if there is a dominant stricture after dilatation, usually we put a temporary stent for 6 weeks to be removed later on. That would be applicable only to the major biliary tree, either the common hepatic duct itself, or the major right posterior or major right anterior, or the left hepatic duct. Strictures in the peripheries do not need to be treated mechanically. Often these people are on autoimmune therapy or immunosuppressive medications because of their ulcerative colitis. But if they are not on, they might benefit from azathioprine as immune suppressive medication. There are other immune modulating medications that have been tried, but generally the results are not very promising. And patients who develop biliary sepsis, and that will happen particularly after intervention with an ERCPs and PTCs, then they could get bacterial cholangitis or ascending cholangitis, and in that case they need a course of antibiotic treatment. However, these occasions are relatively rare. Now, because these patients have a poor absorption for fat and they often have steatorrhea, they will need some supplement of fat-soluble vitamins, particularly vitamin K. The role of surgery is very limited in primary sclerosing cholangitis, apart from if there is a gallbladder cancer that can be treated in the usual manner, provided the patient is compensating with their liver function or child's Pew class A. Also, there's a dominant single stricture that could be malignant, then that can be resected. Or the diagnosis is suspicious for malignancy, then that dominant single stricture can be resected with a hepatico-jejunostomy. There are rare occasions where the disease is very bad at the hilum, and following repeated attempts for dilatation and stenting, the patient keep getting obstructive jaundice and they get sepsis as a result of the RCP and the stents. In those situations, which is very unusual, we could consider complete excision of the extrahepatic biliary tree and do biliary enteric anastomosis. So we anastomose the left duct separate from the right, and often because the hilum is damaged, we need to have at least 3 anastomoses: the posterior sectoral duct, the anterior sectoral duct, and the left hepatic duct. High-risk procedure for bile leak, and fortunately, it is not something that need to be done often. And that's the role of surgery, and where you need to know about primary sclerosing cholangitis in terms of its surgical presentation and management. It mainly crosses with bile duct strictures, and the fact that we know bile duct strictures can be malignant, and that when the patient gets referred to surgery. Also, if they develop cancer of the gallbladder, and if they need an ERCP, the surgeon is going to do an ERCP with the stents and the brushing. Now, occasionally the ERCP can fail due to previous surgery or a variety of technical issues. Then we ask the interventional radiologist to do a PTC. It's a procedure that's done under general anesthesia. The interventional radiologist will identify a dilated intrahepatic duct, and they cannulate that. And after cannulation of that dilated duct, then they could take biopsies, they could put stents, and they could do dilatation and a variety of other procedures. Thank you much for listening to this video. I hope it will answer all your questions about primary sclerosing cholangitis, as this disease in entity tend to be in general of interest to a lot of students, and they do often ask me about primary sclerosing cholangitis, despite the fact that the problem is mostly medical and a rare disease as well. And I will see you in the next video.